Welcome back. We are continuing. In the previous discussion, we were talking about enhanced ways of airway clearance. We talked about humidification, which helps to moisturize the airs, the secretions before they are excreted or before they are pushed out using either manual ways or normal ways. And they are indicated in conditions that thicken the mucus. Okay. We also talked about hydration, which comprised of the techniques that mobilize the mucus and have them out, excrete them. Okay, then we also talked about rib springing, which is aimed at mobilizing the rib cage so that it performs its functions better, and that it could be compromised by a lot of other conditions, which include musculoskeletal conditions. Now we are continuing, we're talking about nebulizations, which we also mentioned, if you remember, we mentioned nebulization in humidification when we were talking about humidification. We talked about using a nebulizer. So let's talk about the process of uh, nebulization. What is it about? Okay. Manual techniques are contraindicated in patients with conditions such as cardiovascular conditions, uh, severe osteoporosis, hemoptysis. These conditions are contraindicated to manual techniques such as the tapotment that we were discussing last time in traditional means of clearing the airways. Nebulization uses a device known as a nebulizer, which is a drug delivery device used to administer medication in form of mist inhaled into the lungs. Nebulizers are commonly used for treatment of conditions such as asthma, cystic fibrosis, and other chronic obstructive pulmonary diseases and other respiratory diseases disorder. Take note that the same nebulizer can also be used to moisturize the secretions, just as we discussed in humidification. Okay, moving on, they use oxygen, compressed air, or ultrasonic power to break up solutions and suspensions into small aerosol droplets that are inhaled from the mouthpiece of the device. An aerosol is a mixture of gas and solid or liquid. Okay, so this suspension fluid, normal saline, as we discussed earlier on in the humidification, will be broken down into aerosol droplets. So this could be an example of the droplets we see in perfume, okay, in perfume, which is also put up in a compressed can like that. When you press perfume, you see some small droplets coming out, okay, that are mist, that are in form of mist. So those are what I refer to as aerosol droplets. Those are coming from a suspension or a solution. So this is what happens in nebulization. So a nebulizer will break down the solution and suspension and make it into small aerosol droplets that can be powered out. Many medications used to treat respiratory diseases can be administered directly into the patient's respiratory system by nebulization, okay, which could also be referred to as inhalation. During nebulization, solutions are converted into aerosol droplets that can be inhaled or delivered into the lung. A proportion of those received by the lung is therefore enhanced, which reduces the dosage needed and the side effects of that medication. Nebulizing a patient with saline, okay, bronchodilator, mucolytic agents before physiotherapy intervention will alleviate the bronchospasms and decrease the viscosity. We decrease the viscosity, which is what our discussion was aimed at in humidification. decreasing the viscosity of mucus in order to facilitate the removal of secretions. This procedure can be performed on both intubated and spontaneously breathing patients and can be combined with postural drainage positions to assist with the drainage of these secretions. Okay, so that is the more reason why you nebulize, and that is what the nebulizer does. Then in trying to clear the airway, you can also do suctioning. Suctioning is an important procedure that aids secretion removal from the airways. It is essential in clearing retained pulmonary secretions from central airways and to maintain a patent airway in intubated patients. Okay. Suctioning of patients who are unable to clear their secretions may reduce the incidence of pulmonary complications such as pneumonia. So you would note that patients like those that are in ICU, they have depressed capacity to clear their own airways. So meaning secretions would be produced and collect in the airway lining. So suctioning comes in very handy to help in clearing secretions in this type of patients. There are two types of suctioning. There is open suction and closed suctioning. Okay. In open suctioning, the patient, in open suctioning, okay, just a second. In open suctioning, the patient is actually disconnected. Okay. The patient is disconnected from the ventilator. The patient is disconnected from the ventilator, and the disposable suction catheter is inserted down the patient's artificial airway. Okay. It has a disadvantage in that in this method, the disadvantage of this method is that the recruitment of the lungs will happen due to loss of patency post-exposure, post-end expiratory pressure, okay, when opening the airway circuit. Enclosed suction involves a suction catheter placed in a protective sheath and connected directly to the ventilator. In this closed sectioning, there is no disconnection. Okay, there is no disconnection. The catheter tubes are just pushed within the endotracheal tube, and the suction happens. Okay, post-suctioning poses fewer risks from environmental cross-contamination as no disconnection is needed, because this one you are just operating on the already established structure, as opposed to open suction where you pull out the secretions, then you reconnect the patient. In that type of, in suctioning as a whole, pre-oxygenation is important. You pre-oxygenate the patient to at least 100% oxygen saturation for at least 1 or 2 minutes before you suction the patient so that you prevent hypoxemia. Okay, otherwise the patient may become hypoxemic because you are pulling as you are trying to pull the secretions out of their airway, the breathing capacity is depressed and they can become hypoxemic. Suctioning should be limited to 5 to 10 seconds while intermittently opening and closing the suction catheter without closing it for more than 5 seconds at a time. It can also be achieved through the oral nasal route and can be used in intubated and non-intubated patients to remove accumulated secretions in the oral nasal region that may lead to micro aspirations and increase the patient's risk of ventilator-associated pneumonia. Some of the side effects of suctioning include episodic hypoxemia, which we've already talked about, increased intracranial pressure, bacterial contamination, and increased oxygen consumption. Okay. Hence, care must be taken and patients' vital signs must be monitored constantly while performing suctioning. Pre-oxygenation and optimal technique minimize the occurrence of these side effects. So before and whilst you are doing suctioning, you intermittently do the oxygenation. You do suction. After an episode of suctioning, you re-oxygenate to 100. Then again, you disconnect, or if you are disconnecting, or you are just doing, if you are doing closed or open suction, then you continue intermittently like that. You do episodes of re-oxygenation. Okay. So there is also a technique known as incentive spirometry or spirometry. Okay. So spirometry is uh, is a process, or it is, yeah, it is a process that deals with the breathing, that studies actually, or let me say it is the whole technique that takes care or records the breathing process as a whole. Yeah, maybe I can put it like that. It records the breathing process as a whole. It takes care of the normal breathing techniques, and then the normal breathing pattern. They are recorded in the process known as spirometry. Okay. So there is what is known as incentive spirometry, which utilizes a device to provide visual feedback in order to encourage patients to breathe deeply. Incentive spirometry is for patients who can cooperate and are able to follow instructions. Okay. It is recommended for spontaneous breathing patients who have developed atelectasis, poor inspiratory muscle strength, and good oxygenation is often used as a prophylactic therapy to patients. Incentive spirometer is a small and portable device that the patient can also use effectively on their own after sufficient instructions is received. So meaning you can actually do this technique on the patient and teach them how to do it at home. They can actually even purchase this small device and continue with the techniques at home. There are two types of incentive spirometers. There is one that is known as flow incentive spirometry, in which the magnitude of airflow during inhalation is indicated by the number of bars and the level to which they rise. The other one is known as volume incentive spirometry, in which volume of air displaced during inhalation is indicated on a scale marked on the device. So these are the two types of spirometers. This one is motivated or characterized by the boss. So the incentive is the benefit that the patient sees or that the patient gains from an activity. So the patient will be given instructions to breathe, and as they are breathing in, they can see the balls rise, and that is trying to get to the goal, or trying to make sure that the balls rise further or much higher. The patient to follow the instructions as they are trying to see this incentive. Okay. Or it can be spirometry, that it can be to using the go marker. Okay, the other one is using the bow, the other one is using the go marker. Okay, so it can be following these goals and the volumes there. Okay, you can see the volume, marked volumes. So as the patient is breathing, they are able to see the marks on the volume. So if they breathe in today, they reach at 1,500. The next time they should work harder to take it to 2,000 or 2,500, and just going up like that, that is going to give them an incentive to work harder and harder so that they are even able to see their improvement. The incentive spirometer is activated by inspiration. Okay, patients are instructed to take a slow, deep breath through the mouthpiece and their lips sealed around the mouthpiece to maximally distribute air. Ongoing inspiration is encouraged by visual feedback, for example, by seeing the ball or by seeing the goal marker. They are encouraged or by seeing how they are managing to raise the ball, and that sets them, makes them work harder so that they can do better by trying to see that the goal they're trying to work towards is attained is attained well, meaning they are improving. Okay, it is marking their improvement, and they are able to also mark or observe how better they are doing. Depending on the purpose, the deep inspiration can be followed by an inspiratory hold for about 3 to 5 seconds. Okay, then normal expiration. So this, depending on what you want, as the patient is trying to breathe in. Remember, we talked about diaphragmatic breathing when we were talking about traditional means of physiotherapy, airway clearance. This one is the means achieving the same as diaphragmatic exercises, but using the device. Depending on what you need, we said in diaphragmatic exercises, you can couple the diaphragmatic exercises with a hold, okay, normal expiration, or forced expiratory techniques, including a cough, depending on what you want to achieve. So if what you want to achieve is airway clearance, they can breathe in, push up the balls or the volume to as high as they can. Then when breathing out, you put up any of this, a forced expiratory technique, they have or they cough at the end of it. Patients should be monitored during this technique to avoid hyperventilation and use of accessory muscles leading to fatigue. Okay. Post-expiratory pressure devices. Among them, we have post-expiratory pressure, which is PEP, okay, which is another secretion clearance technique that involves the patient breathing out against resistance in order to create positive airway pressure. Okay, so mark that one. The patient is breathing out against the resistance in order to create positive pressure. Okay, it involves the use of devices that deliver positive pressure to the airway. So PEP devices commonly utilized a one-way valve that allows unrestricted inspiration and resistance to expiration through the resistor valves. Okay? Note that this unrestricted inspiration allows as much air as possible to go in and restrict the expiration so that it creates this positive air pressure. The resultant positive air pressure produced during expiration encourages airway sprinting, preventing airway collapse. Okay. So these techniques, the air accumulated behind the secretions also forces the secretions from the peripheral to the central airways so that now the other techniques like the coughing techniques, forced expiratory techniques can clear the air from the from the central airways. Following these secretions, following these effects, the main indications for PEP therapy are therefore retained secretions and atelectasis. So following retained secretions and atelectasis, these will be indicated, and you will use this technique so that air is brought to the central, the secretions are brought to the central part and they are excreted. Okay. So there are three types of PEP devices: flow resistor, threshold resistor, inspiratory resistor. Flow resistor patients exhale against the fixed size of orifice based on age and expiratory flow. Threshold patients exhale against an adjustable spring-loaded valve or reverse venturi device. The same as the other one in which the vibratory PEP, which could be either the instrument referred to as the a cappella or the flutter. Patients exhale against a threshold resistor with an expiratory valve oscillating, okay? It's oscillating at about that, those hertz, 10 to 30 hertz, okay? So these are main types of the PEP, and the technique continues, but the aim is to have positive pressure build so that they clear the air. Okay, so these are just how it can be done. PEP is most suited for secretion clearance, and after each cycle, the patient can make use of FET supported by cough. So all those other techniques that we have been talking about can be used, can be employed while it's doing this, while using a device that is building positive expiratory pressure. Okay, so there are also devices that are non-invasive, that push in non-invasive, or that work with non-invasive ventilatory techniques. Among them are the following. So this technique where the positive pressure is administered to the lungs and airways without the need for the endotracheal or tracheostomy tube. They are non-invasive, by the way, so take note of that. These devices are used to improve gas exchange, improve lung volume in order to keep the airways open during respiration. They reduce the work of breathing and alleviate symptoms of respiratory insufficiency. Amongst them, we have those that give intermediate positive pressure ventilation devices. Okay, so these IPB devices are used to maintain positive pressure in the airways of non-intubated patients during inspiration, with the airway pressure returning to atmospheric pressure during expiration. Intermittent positive pressure breathing assists in increasing tidal volumes and reduces shortness of breath and atelectasis, while reducing the work of breathing during inspiration. The following parameters can be set by a physiotherapist, in which the position of the patient during IPB depends on the indication for the treatment, but should be comfortable. So meaning you assess the patient and position them in the most comfortable position. Mostly it could be positioned in semi-fowler's position, in which you can safely administer this technique. The patient should then relax and allow the machine to assist them to breathe after they are put in the position of their comfort, and the machine is connected accordingly. Then the patient should relax and allow the machine to assist them to do deep breathing accordingly. IPP is contraindicated in patients with tension pneumothorax, lung abscess, severe hematitis, as well as bronchial tumors, among other contraindications. Inspiratory muscle training is also very important, in which inspiratory muscles, like other skeletal muscles, are also at risk of atrophy and weakness when they are not used optimally. Okay, so long-term immobilization, that is bed rest, and mechanical ventilation can cause pronounced muscle atrophy, which includes the inspiratory muscles, resulting in inspiratory muscle weaknesses, amongst other techniques. This will make them lose inspiratory muscle endurance, difficulty in weaning off the ventilator, as well as many other respiratory complications may arise. Techniques such as incentive spirometry, deep breathing exercises, and ACBTs and the use of inspiratory muscle training devices such as effective in preventing and retraining inspiratory muscles will help in maintaining the integrity of these muscles. Inspiratory muscle training devices and techniques are safe to use in all intubated patients, provided they understand how to use the device and breathe spontaneously for short periods. Okay, so this is about these techniques. Thank you so much for listening. See you.